I'm just gonna say that surgery is just the tip of the iceberg. And what do I mean by that is that surgery is extremely important, as Dr. Pena just mentioned, because we always say patients with colorectal conditions, they have one chance to have the right operation. A reoperation change for bad the prognosis for future bowel control. So having the right surgery is extremely important, but I don't want anyone to think that surgery is everything. And I think this picture shows the importance of what comes after, the long-term follow-up. So the prognosis for bowel control in patients with anorectal malformation is determined by the quality of the sacrum, the type of anorectal malformation, the tetrachord status, and a technically correct operation. So first we're going to go through each type of anorectal malformation, starting with the most benign rectoperineal fistula. So here we are seeing a patient cut like this. So this is a male patient. So here would be the bladder, here is the rectum, and you can see that it opens anterior to the center of the sphincter. And in a female, same thing, here's the bladder, here's the uterus, the vagina, and again, the fistula opens anterior to what should be the center of the sphincter. This is the most benign type of anorectal malformation. It has an excellent prognosis for bowel control when they have a normal sacrum, about 100% chance of bowel control. But because they have good chance for bowel control, they also suffer from the worst type of constipation, and this cannot be ignored. The most common malformation in females is called rectovestibular fistula. So in this case, we can see the urethra, the vagina, and the fistula is right here at the vestibule, right posterior to the vagina, and it shares a common wall with the vagina. So during the surgery, we have to do a meticulous separation between the rectum and the vagina. This malformation also has an excellent prognosis for bowel control. About 95% of the patients will have bowel control when they have a normal sacrum, but they will also suffer from severe constipation. The true only imperforate anus is this type of anomaly that we don't know why, but it happens more common in patients with trisomy 21 or Down syndrome. And it's when the rectum is actually blind. So it's an imperforate anus without a fistula. But even when there is no fistula, there is still a very intimate contact with the urinary tract. So the separation from the urethra is a very delicate portion of the operation. These patients also have an excellent prognosis for bowel control, but they suffer from severe constipation. Probably the most common type of malformation in male patients is the recto-urethral-bulbar fistula. So here you can see the bladder, the urethra, and at this curve, when the urethra is a little more dilated, it's what we call bulbar urethra. So in this case, the rectum opens at the level of the bulbar urethra, but again, it has a common wall with the urethra that requires meticulous separation to preserve the urinary tract and important structures. The next malformation is called rectourethral prostatic fistula. So as you can see, here is the bladder, and here is where the prostate is located. It's almost like in the middle of this section here. And again, the rectum still has a common wall with the urinary tract. This malformation doesn't have an excellent prognosis. It's about only 65% of the patients that will have bowel control. And the highest type of anorectal malformation in male patients is called rectal bladder neck fistula because the rectum opens at the level of the bladder neck. So this is the only malformation in male patients in which the separation of the rectum from the urinary tract can only be done through the abdomen. meaning either through a laparotomy or laparoscopy. Prognosis for bowel control is not good. About 15% of the patients will have bowel control. And Dr. Pena already mentioned cloaca in female patients. It's when a little girl, instead of being born with 3 orifices, she's born with a single perineal orifice. And then there is a common channel and until the structures trifurcate. And this common channel can vary in length. So we consider a short common channel when it's less than 3 centimeters. So when we have a cloaca with a short common channel and a good sacrum, about 70% of them will have bowel control. Now, when we have a cloaca with a long common channel, more than 3 centimeters, usually those patients do not have bowel control, and they will need intermittent catheterization to empty their bladder. The most complex type of anorectal malformation is called cloacal ectasis. That's a defect in the abdominal wall, and the patients are born with an omphalocele. It's when the bowel is outside the abdomen and it's covered by a membrane, and then 2 hemibladders and a piece of bowel prolapse, like protruding in between those 2 hemibladders. So this is an example about the importance of a good multidisciplinary team since day 1 of life, so the patient can achieve the best prognosis on each area. How do we determine if the patient has a good sacrum or a bad sacrum? We get a simple sacral X-ray, AP and lateral, and we calculate the sacral ratio. It's a measurement, so we can have an objective way to tell how the sacrum of this patient is. So the way we do it is we draw a line in the direction of the sacrum, then at the top of the iliac crest, at the sacral-iliac junction, and at the last bone that we can see of the sacrum. And then we divide the distance between these 2 lines by the distance between these 2 lines. If we have a value of 0.7 or above, this is a good sacrum. If we have a value of 0.4 or less, since day 1 in life, we can tell the family that the prognosis for bowel control is not good. And we like to do an AP and a lateral version because the sacrum may have different angles. So if you only do AP and there's an angle, it may appear to be short. So the lateral is the most important one. Why do we have to do the AP? Because we have to look at sacral defects that the lateral view would not show. Now, when the baby is born, even if the baby is born without a sacrum, we have to remember fecal incontinence is normal at birth. Every baby is wearing diapers. So at this age, it really does not matter. But it's important to tell the family early in life so we can decide what is the timeline and when a treatment should be implemented. So when the patient is born with a malformation that carries good prognosis for bowel control, most of these patients will need laxatives to adequately empty their bowel. And when a patient is born with a malformation that has poor prognosis for bowel control, those patients will need enemas in order to be clean in the underwear. So for patients that need laxatives, we have to find the right amount of laxatives. This is very individual, and the only way to know for sure if the patient is actually empty the colon is to get an abdominal X-ray film. Patients with anorectal malformation, they often need fiber, because what happens with the laxatives, it has a tendency to produce more liquid stool. And patients with anorectal malformation, it will be harder for them to feel liquid stool. So we need the right consistency of the stool, and the fiber helps give bulk. So that's why most patients with anorectal malformation will need laxatives and fiber. finding the right dosage is the key for success. Now, for patients with enemas, what we do is we have to find a specific recipe that will work for the patient. We normally use a Foley catheter that we insert through the rectum, inflate the balloon, pull back to act as a plug, and then we're going to infuse this specially designed recipe and let it stay there for 5 to 10 minutes so it mixes with the stool, and then the patient will sit in the toilet and evacuate for about 45 minutes. So the goal is that we will have a clean rectum and a clean left colon, so there will be nothing to come out during the day. And that's how we keep the patient artificially clean, because it takes 24 hours for the stool in the right colon to again reach the rectum. So this is the simple concept of what bowel management means, but it takes time and dedication to find the specific recipe for each patient. And I cannot overemphasize the importance of the abdominal radiograph. Even when a patient can come to us and say, yeah, my child is doing fine and they're stooling every day, then we get the abdominal x-ray and we can see in this image, all this granulation here, all of this is stool. So this patient is basically fecally impacted. Even if the parents tell, yeah, he's stooling every day or she's stooling every day, the x-ray gives us an objective way to evaluate if the patient is actually empty. And in the case of enema, if the enema actually cleaned the colon. So just so you can see the difference, here we have an abdominal radiograph full of stool. And in this one, we can see a rectum completely clean and a descending colon completely clean, transverse colon clean. And here in the right colon, we can see a little bit of stool. So the abdominal radiograph is extremely important. And if we find that the patient will need enemas for life to stay clean, that's when we will discuss with the family and the patient the option of having an antegrade enema procedure. So here is the video that I just showed when we are giving enemas from the rectum. And what an antegrade enema procedure means that the solution will now be entering from the beginning of the colon. So in this case, we're showing a Malone procedure. Is when we connect the appendix to the belly button, and then the patient will sit in the toilet, pass this little catheter, it's a very small catheter, and then flush the colon while seated in the toilet. So there are different types of antegrade enema procedure. Again, here's the Malone, is when we connect the appendix to the belly button, and we like to plicate the cecum. It's almost as the cecum gives a hug in the appendix to avoid leakage of stool. And then there are other devices that can be used in the Malone or can be used directly in the cecum, in this portion of the colon. So this is called the Chait tube, and some patients, they don't like to have to pass the catheter every day, so they prefer to have a permanent tube, which is unusual, but some patients do prefer. So that's the Chait tube. Again, it can be inserted into the Malone or it can be inserted directly in the cecum. And that's called the mini ACE, that in this picture is being inserted into the Malone, and in this picture is being inserted into the cecum. The difference between the mini ACE is that it has a balloon. So for patients that even when we have done the plication and the patient still leaks, sometimes this is a good alternative. The advantage of the Malone is that in most of the cases, we don't need to keep any tube. So the patient just passes the little catheter, give himself or herself an enema, take it out and be done. And with the Chait tube or the mini ACE, the tube has to be all the time in the abdomen. Some patients, they don't have an appendix either because the appendix was taken out or because sometimes the urologist uses it for the Mitrofanov. So in those cases, we'll have to make an appendix, and we call that a neomalone. And we do by raising a flap out of the cecum, and then we tubularize just like an appendix. Again, we try to create this valve-like mechanism to avoid leakage, and then we suture this portion, we connect this portion to the belly button. I know Dr. Peña already talked about the multidisciplinary team, and I think it's extremely important. And it's not just having different pieces. I think most hospitals will have a pediatric surgeon, a urologist, a gynecologist, but what makes a successful multidisciplinary team are people that have their mindset through the same problem. It's people that work together well, people that trust each other, people that often operate together. And I think we're extremely proud of the team that we have here at Children's Hospital Colorado, where we get along extremely well, we respect each other, we operate together very often. And for the families, I think going to the clinic and being able to see different providers at the same time, knowing that they are talking to each other is very helpful too. And what are the checkpoints for patients with anorectal malformation? So I think during the newborn period, we need a full evaluation. We want to rule out all the associated anomalies, but we also want to draw what's the plan for the future. Parents, when they have a kid, they would like, especially a child with a malformation, they want to know what will be the limitations, what are the potentials for my kids, what will hold them back. So I think being able to draw a plan is very helpful to them. Once we have either the colostomy or in some case the primary repair, then we're just going to follow the growth curve. We just want to make sure that baby is growing, eating, and acting as a baby as much as possible. Now, once solid food starts, either after the posterior sagittal approach or after the colostomy closure, that's when we have to be extremely vigilant about constipation, especially for patients that were being breastfed and suddenly they change to solid food. That's when we see the constipation really happening. So during the early stage until toilet training, our obligation is to manage constipation. Patients should be having bowel movements every single day, and we have to make sure they are actually empty their colon. Then comes toilet training age. We normally tell our parents, try to toilet train your child. And for some kids, in order to be out of diaper, if they fail toilet training, that's when we will recommend starting formal bowel management to be clean in the underwear. At the beginning of school, we want to make sure things are under control, that there is a plan, that there is a psychosocial evaluation, that you know what are the resources that you can have at school. Then, if we had, for patients that have borderline bowel control and we had to start them on enemas, we like during vacation time to give them an opportunity to try to stop enemas and see if they respond to what we call laxative trial. We will try to stop enemas and some of them will need some laxatives. If they are successful, then they now change their treatment. If they are not successful, we go back to enemas, give them another year. And as the child becomes more independent, if enemas are the treatment of choice, then it's when we're going to start discussing with parents and child when is the right time for an antegrade enema procedure. Ideal follow-up for colorectal, I know this was one of the questions. I like to hear from my patients at least once a year to confirm that the bowel management continues to work, and also combine visit with other specialties, urology for male and female, and gynecology for all female patients. We want to be watching the patient and detect early if there is any problem that it's arising. We need to check on them during puberty too. and then later in life for fertility, sexual, and reproductive function. And I know Dr. Peña already talked about transition of care, that it's an area of great interest for us. I think that's one of the main reasons why we moved to Colorado, because it almost became a routine that we would receive a phone call of an adult patient trying to seek care. And when they arrive in the hospital, the doctors didn't want to take care of them because they were unfamiliar with anorectal malformation, Malone, Mitrofanov, bladder augmentation. And we thought we have to change this. This cannot continue like that. So we are very happy that here we have the University Hospital next to us. And if a patient is in need, there is collaboration to assist these patients. And I think this will grow. We are almost watching the birth of a new specialty that are adult surgeons that are familiar with congenital conditions. So thank you very much for joining us today. And it's my pleasure now to invite Dr. Luis de la Torre, who is our partner, and Sabrina will unmute him so he can give his talk. Thank you.